So my name is Ona Bloom. I am not a clinician, so I don't know how many non-clinicians you've had in this series. So I think I have multiple missions for this talk. So I'm a PhD. My PhD training was actually in neuroscience, and my postdoc was in immunology. And I'm now a professor in the Department of Physical Medicine and Rehabilitation at the Zucker School of Medicine at Hofstra Northwell. And I'm the director of a lab of spinal cord injury research at our Health Systems Research Institute, which is called the Feinstein Institute for Medical Research. And I think you have all been introduced to the structure of Northwell at some point, but I will cover that in a moment. And I also have an appointment at our local VA, which is the James J. Peters VA Medical Center in the Bronx, New York. And I'd really like to thank the organizers for including me and Josh for moderating. It's really wonderful to be included in this great series. Okay, I'm getting that. But okay, so before I start my talk, I just wanted to acknowledge I have two really spectacular main collaborators. The first is Dr. Adam Stein, who is our chairman of the Department of Physical Medicine and Rehabilitation. And he happens to be a spinal cord injury doctor. He's the current president of the Association of Academic Physiatry. So I know we have trainees at multiple levels here. So physiatry is the word that is used to describe the physical medicine and rehabilitation doctors. So it's a kind of funny word, and PM&R is the acronym that we often use, and physiatry is you will say a physiatrist is in the department of PM&R. So those are the docs. We also work very closely with Dr. Matthew Bank, who is the director of our Level 1 Trauma Center for Adults at North Shore University Hospital. And it's really been a terrific collaboration, and all of the work that I'm going to talk about in the second part of my talk has been the result of work, collaborative work. Again, since we have a lot of trainees at different levels, I wanted to put up some examples of resources where people can learn more about spinal cord injury. It's a very complicated topic that just hits a lot of different aspects of life and health. So there are professional societies such as the American Spinal Injury Association. You may hear me refer to Asia throughout the talk for various reasons. And I'm referring to the professional society, not the continent. The International Spinal Cord Society, the National Neurotrauma Society. There are websites like the Spinal Cord Injury Research Evidence Project, which aims to describe clinical trials in the area of spinal cord injury. NIH has an information page, the VA as well, clinicaltrials.gov. And for consumers as well as for people who are new to the field, I highly recommend the Christopher and Dana Reeve Foundation has a terrific website which is aimed at lay language descriptions of all kinds of different aspects of spinal cord injury. And then I also want to give a shout out to my colleagues who in this era have started the International Online Spinal Cord Injury Research Seminar Series. And you can find that on YouTube. And it's really been a great galvanizing effort, similar to the one that you're participating in now, just focused on the topic of spinal cord injury. I also wanted to give some references if people want to learn more about spinal cord injury. So here again is a little screenshot from the Christopher and Dana Reeve Foundation's website. I'm going to use, for my introductory part of the lecture today, a primer from Dr. Michael Feelings, who I thought this was particularly appropriate for the neurosurgery department. So Dr. Feelings is a neurosurgeon in Canada. He's one of the premier spine surgeons in our field. And he and his colleagues wrote a really beautiful, almost textbook, condensed in as much as possible on spinal cord injury. And if people are looking for a really complete introduction, this is what most of the figures are going to be from for the beginning of the talk. I also referenced another great review, which at this point is considered old by current standards, but is really, really thorough and terrific as an introduction to what's going on in the field. For people who are medical students or even residents, this is the classic textbook by Dr. Kirschblum, who is at Kessler Foundation in New Jersey, and is also the chair of the Department of PM&R at Rutgers. And then I'm going to speak a bit about my own research, which is focused on inflammation and immune function. And there's a review there's a journal that's dedicated, there's an issue of this journal that's dedicated to reviewing the historical literature on immune function and SCI, and that's the reference there. So there's lots to talk about in this field. I'm going to start as if nobody has any idea about what I'm talking about, so forgive me if this is too simplistic for many of you in the audience, but let's start by talking about what does the spinal cord do. So it's, at the simplest level, it's a network for communication between the periphery and the brain. So neurons carry information from the skin, muscles, joints, and internal organs to the spinal cord about pain, temperature, touch, vibration, and proprioception, and they relay information to the brain. And each segment of the spinal cord receives information from specific parts of the body, and then the brain sends back signals through the spinal cord to control voluntary and involuntary movements, regulate internal organs, blood pressure, hormone regulation, sexual function, bowel and bladder function. So the spinal column, the vertebrae, the bony vertebrae usually protect the spinal cord from damage. And so what actually damages the spinal cord in a traumatic injury is typically the fragments of bone that hit the spinal cord. And so this is just a little map on the right-hand side, adapted from the Christopher and Dana Reeve Foundation, showing how the level of the injury, so where you've been injured, really affects the kind of functions that are going to be impaired or modified after injury. So I should mention one thing, which is that everything that I'm going to talk about today is related to traumatic spinal cord injury. So an injury that results from a trauma, like a car accident or a fall or a diving accident. But obviously many of the issues will also apply to non-traumatic injuries, such as cancer, like you heard Dr. Patel speaking about in the previous talk. Okay, so I'm not a clinician and I'm not an anatomist, so I'm just putting this up here as a little bit more detailed version. This is all from the Michael Feelings article that I referenced. This is a beautiful figure where he describes how the white matter tracts convey information to the brain or descending to the periphery. Sensory information and motor information is conveyed separately. This is a drawing here on the right of how the skin is innervated. And on the bottom is a reference to key muscle groups that are tested in a clinical exam when people are examined for spinal cord injury. And I'm going to talk about that more in depth in a moment. Okay, so let's just learn a little bit about sort of the facts and figures in the United States. So we don't have a national health system, as many of you are aware. And so we don't track people throughout their lives in terms of their health. But what we do have in this field is the National Spinal Cord Injury Database, which is maintained by the NIH, and it captures about 6% of new cases in the United States. And there are 14 different centers around the US that are designated as NIH designated model systems in spinal cord injury. And they collect and contribute the data from their patients, and then statisticians sort of extrapolate the statistics from these model systems data. And the reason that these are called model systems, and that's going to become apparent later on in my talk, is, spinal cord injury requires very specialized multidimensional care, and not every institution has the breadth of expertise to do that. And so what the NIH has set up in an analogous fashion to level 1 trauma centers, they have set up what they call designations of centers of excellence for spinal cord injury care, and they're regional. And so it's not every state, far from it. There's 14 in the country. And so, if you're lucky to be near one, that's where the most comprehensive care is typically given for the most severely injured people. Okay, so the incidence and prevalence are given here. There's about 17,000 new traumatic injuries in the United States each year. The prevalence in the US, this is a number that floats around, but it's more than 350,000 people who are living with chronic spinal cord injury. The average age has increased from 29 years old in the 1970s to now the 40s, but that's really That's really the average. There are really two different populations. There are younger people who get injured, and there are an increasing number of older people who get injured, and their etiologies of injury are different. So older people are most often injured due to a fall, and younger people are often injured due to a motor vehicle accident. And this is just to make the point that, as I said, I'm going to talk today about traumatic SCI, but the Christopher and Dana Reeve Foundation has some global statistics on paralysis itself, which, if you use that as the definition, really affects millions and millions of people worldwide. And mobility issues, affect many of us as we will age, and a lot of what I'm talking about today may impact other populations. Okay, so most cases of spinal cord injury are male. Motor vehicle crashes are the leading cause of injury, followed by falls, as I just said. Lengths of stay in the acute care hospital have declined from 24 days in the 1970s to 11 days recently, and I think that's a really remarkable thing to think about when you consider people often have questions about clinical care, retraining people, and think about how much has to be accomplished in 11 days. If you've ever moved to a new neighborhood, you can think about how disoriented you are for the first, several months. And so think about the length of stay is 11 days in the United States, I should say. Okay, neurological level and extent of lesions. So incomplete tetraplegia, meaning all four limbs are affected, is the most common type of injury. And we're going to talk a little bit about what incomplete and complete mean in a moment. I didn't realize those terms are used here. Paraplegia is obviously the lower limbs, and tetraplegia is all four limbs. Okay. Here's some information about education, marital status, occupational status for people with spinal cord injury. But what I wanted to draw your attention to here is the rates of rehospitalization. So about 30% of people with spinal cord injury are rehospitalized one or more times anytime during the first year after injury. The length of stay is high, and the reason for being rehospitalized is most often infections. And they're either UTI related or respiratory related. And so we'll come back to that later on in the talk. Okay. It's incredibly expensive to care for people with spinal cord injury in terms of the economic costs. So here are some staggering numbers. And again, all of these numbers are in the United States. High tetraplegia can be, for a person who's injured at age 25, more than $5 million. And historical life expectancy. So despite the fact that we've really improved acute care and all kinds of aspects of medical care since the 1970s, the life expectancies for people with spinal cord injury have not significantly increased. And the leading causes of death are pneumonia and sepsis, septicemia, so infections. And these have been the leading causes of death for almost as long as the National Spinal Cord Injury Statistical Center has been tracking this. Other rates are going up, like cardiovascular disease, but really infections are what we're looking at. Okay, so what happens to people who have a traumatic injury? So let's take the example of a motor vehicle accident. So an ambulance will take them in the United States to the closest level 1 trauma center. And the trauma centers are staffed, as many of you know, by a collaborative team of trauma surgeons, neurosurgeons, and some also orthopedic surgeons. There are designated trauma centers for acute and for adult and pediatric populations. At Northwell, we have both adult and pediatric designated level 1 trauma centers. And once people get out of the acute setting, not all places have a department of PM&R. Sometimes they're a division of neurology. Sometimes there's not. There's neurology colleagues who sort of do similar job aspects or care aspects. But the department of PM&R would be the sort of medical home for people with spinal cord injury for both inpatient and outpatient rehabilitation. And Historically, they've really been leaders in taking a multidisciplinary approach to medical care because people with spinal cord injury have so many multifaceted clinical needs that they really work as a team with physical therapy, occupational therapy, there could be speech therapy, recreational therapy, neuropsychology, social work, etc. And then on an ongoing basis, very often people with spinal cord injury continue to see their spinal cord injury doctor for all aspects of their care because there are many general providers who either don't have offices that are adaptive in terms of their accessibility, or they're not familiar with some of the many issues that people with SCI are living with. And so very often physiatrists who are spinal cord injury docs have relationships with their patients for decades. So it's a very interesting thing to observe as a non-clinician to see, you know, I don't have a doctor who I've been seeing for 30 years. You can really see the as Dr. Patel was talking about, the human touch, the interaction is so important. So what I just described to you here is the ideal scenario. There are many places in this country and elsewhere where people don't have access to this level of excellent care. And so, you know, that's just something to think about. And really, I would be remiss if I don't mention that, you know, prevention is the key. So all of these texting and driving, you know, PSA announcements and anything that you can do to increase your attention while driving is a great thing to do, and to decrease your distractions. Okay, so not surprisingly, the functional deficits that people experience reflect the anatomical injury itself, and no two injuries are alike. These are often very idiosyncratic scenarios, and so I'm not going to go through this in great detail. I just wanted to mention this. And again, this is from Dr. Failing's article that describes how the different tracts are organized in the spinal cord. And depending on how people are injured or where they're injured, their functional deficits are going to reflect that. And there are names for the different types of patterns of syndromes that people experience. And sometimes they're more dominated by motor impairments, depending on the tracts that are affected, or sensory impairments, or you can have a combination. There could be a sidedness to it in terms of where the injury is, etc. So I just wanted to mention that as a concept. Okay, so how are injuries actually evaluated in the clinic? And again, I don't do these exams. I'm not a clinician, but I'm describing to you how this is done. So obviously, imaging plays a part. Sometimes there's electrophysiology. And then the gold standard clinically is now called the INSCI exam. So this is the International Standards for the Neurological Classification of Spinal Cord Injury. And this has been adopted by both the American Spinal Injury Association and the International Spinal Injury Association. If anybody's interested in getting trained on how to do this exam, there's free e-learning and certification on the Asia website. And essentially what this is a motor and sensory exam that a physiatrist or a neurosurgeon or anyone who's trained to do this exam will perform, where they basically test how a person can feel throughout the body, what they feel, and they'll test both light touch with a Q-tip and pinprick with a little safety pin, and they'll use the face as a reference point and say, you know, can you feel this? Can you feel that? And move systematically throughout the body. And then they'll also do muscle testing to see how a person can move. And this grading system is very elaborate and described here, and it's also very, it's a living exam in the sense that it's constantly being updated, and people are testing different ways that it's applied. You know, it's an anatomical description, and there is some function, but it doesn't really tell you how a person is going to be living with SCI. It gives you a general sense of the anatomical deficit. So there are other scales that are used, such as the spinal cord independence measure, where it's a survey-based tool where people will go through systematically and say, okay, how is this person eating in terms of, do they need an assistive device? How is this person going to the bathroom? How is this person breathing? Is this person able to ambulate? If so, what kind of assistance do they need? So there's other ways to score those kinds of functional deficits. And based on the results of this exam, the injury is classified as ASIA A, B, C, or D, and E is normal. A is the most impaired, so there's no motor or sensory function preserved below the lesion. And this very confusing thing in the beginning when you're learning this exam is that A, B, C, or D can be for any neurological level of injury. So somebody could be a C5 ASIA A, or somebody could be a T12 ASIA A. So the level of injury is different than the severity of the injury. And so the severity of the injury and the level are both captured in this exam. And one of the things that's very much discussed in our field right now is the wording complete and incomplete. So there's a common misconception that when people say a complete injury, that means anatomically complete. And in fact, it rarely does. So it doesn't mean that there are no fibers that have been spared. It just means that from a functional perspective, that person was not able to respond in the exam to show some functionality of those connections. So that has a lot of implications for clinical trials and applications that we're going to talk about in a moment. Actually now. Okay, so if you want to see neurosurgeons get excited, you can ask them about the 3 national clinical trials of steroids and spinal cord injury, the NASCI's trials. So unfortunately, we do not have an FDA-approved pharmacological therapy for acute spinal cord injury. The 3 national clinical trials that were performed in the US for steroids were, let's say, inconclusive, and the current guidelines, professional guidelines, do not recommend their use. Surgery is often used to realign the spinal cord, reestablish stability, and decompression with the idea that time is spine in the same way that time is brain and stroke. And rehabilitation is used to enhance the restoration of function with compensation for function and safety. And then there's an ongoing management of the medical consequences of SCI, which I'm going to spend a good bit of time talking about. So, you know, in my early days of training, there was really not a concept of plasticity, neuroplasticity, or neurogenesis in adult mammals. And that really changed during my training, where people learned through basic science studies and then later in human studies that the adult mammalian central nervous system can actually have some extent of plasticity, and there is some evidence of neurogenesis, although that's also a hotly debated topic in the field. Nonetheless, it really ushered in, I think, a new phase of clinical trials and therapeutic approaches that are being tried in both the acute phase and the chronic phase. And acute and chronic mean different things in different disease settings. So in the context of traumatic spinal cord injury, acute typically means the first couple of days. Then there's a subacute phase, which could be weeks or months. And then chronic is often used either to denote 6 months or 1 year from the initial injury. And the reason that many of us use 1 year is that that's the time when statistically, without any experimental therapeutic intervention, most people reach their neurological sort of level of function during their level of recovery during that first year with the current standard of care that we have. That's not to say that that's all that can be achieved. It's just that's the current statistics in the current setting. So lots of different modalities are being tried in clinical trials in spinal cord injury. So there's different pharmacological trials. So drugs like minocycline and riluzole are being tested in the acute phase. There are scaffolds that are being tried with the idea, and we'll talk about this in a minute with the biological events at the spinal cord, but there's a lot of rearrangement of the tissue. And so identifying ways to have permissive environments in the cord or sort of Band-Aid approaches, if you will, is of interest. Cell transplantation. So there are a couple of different cell types that are being tested in terms of their effects in spinal cord injury. Environmental conditions. So again, as this is a neurosurgical sponsored series, controlled hypothermia has been tried acutely. Intermittent hypoxia is being tried chronically, which is a very interesting and exciting potential therapeutic intervention. This is really the phase of neuromodulation. So devices are being used increasingly, both implanted as well as external. So epidural stimulation, which is an implanted device, as well as transcutaneous stimulation. Both of those are being paired with rehabilitation paradigms. There are external devices like robotic devices called exoskeletons, which are a way of, it's an assistive device for walking, and the Centers for Medicaid and Medicare in the United States, which set the insurance and billing codes, have just approved a new code for one particular exoskeleton made by the company Reeve, and I'm sure that others will follow suit. And that's a really big deal for the field, because many of these exoskeletal devices, which enable people to stand and walk, are very, very expensive, and they were seen as an alternative to a wheelchair, which is much less expensive. So now that there's a billing code, that's a real game changer. People are trying diets. There's a ketogenic diet that's being tried in the acute setting. People have tested or are testing anti-inflammatory diets in the chronic setting to try to manage different aspects of living with spinal cord injury. And, you know, this is a young field. We're still in the observational phase. So understanding, and I'm going to talk about this with my own work, understanding different aspects of the body that can serve as biomarkers of both neurological injury severity as well as potentially prognostic of recovery is very much of interest. And you know, different modalities or different tissues are being tested in that context. So blood, cerebrospinal fluid, there are imaging methods that are being used, because we still don't have a phenomenal understanding of what are the steps that happen in people from the acute to chronic phase in the body that most influence recovery and long-term health. Okay, so if we think about, or the way I think about the major challenges in spinal cord injury research, there are a couple of big obvious questions. How can we limit the acute secondary damage after the injury, which arises from inflammation? And I'm going to explain more about each of these things in a moment. And that's really the concept of neuroprotection. How can we promote repair of the spinal cord in the subacute and chronic phase, either through regeneration or plasticity or both? How do we promote success in the rehabilitation phase for functional recovery? Do we also need to reduce inflammation there? And how do we manage the consequences of living with spinal cord injury, promote general health and quality of life? Does that also involve ongoing reduction of inflammation and improving immunity? And again, I'll touch on all of these aspects in the rest of the talk. So to meet these challenges, we really need to understand more about the basic cellular and molecular cascades that are triggered by SCI, both intrinsic to the neurons and then also in the surrounding tissue as well as in the whole body. And then once we have a sense of what those are, how can we modulate them to promote the best possible outcomes? And so research is being done in this field in animal models, which I'll refer to as preclinical studies, as well as in human studies, which are both studies and trials. And the difference that I'm referring to here is studies would be the observational studies, and trials are where you have an intervention. Okay, so I'm not going to spend a lot of time on this, but I just wanted to point out, since we have trainees at many different levels, that many different model organisms or living creatures are used to study different aspects of spinal cord injury and regeneration. And I've listed some of them here, or I've made little pictures of them. And they range throughout the phylogenetic tree. So there's a lot that's being done. And even in animals like C. elegans that don't have a spinal cord, people are studying different aspects of basic neuronal biology after injury. And there are different types of spinal cord injury models, traumatic spinal cord injury models. So some of them are physical, where they produce a compression or a contusion. Sometimes there's a transection, partial or complete. Sometimes there's an ischemic injury. Toxins can be used. There are genetic approaches to target particular cell types, for example. People study primarily the acute phases with less done in the chronic phase in preclinical models. Both observational and interventional studies are being done in preclinical research. And on the interventional level, there's a recognition that, you know, it's not going to be a single thing in this field that's going to be a magic bullet. There's probably going to have to be a combinatorial approach, as there are in many other disease settings, such as cancer, where Dr. Patel was just speaking about. And then there's many different types of, for example, sources of cells or other kinds of things that are being tested in these models. So there are lots of organisms that actually do regenerate and recover functionally from spinal cord injury. And this is something that I just like to point out, because we often mostly study the condition in mammals where it's not spontaneously successful. But there are other creatures out there that can do this successfully, can repair and regenerate and recover functionally after injury. And some of them are listed here. And I just wanted to give a shout out to a collaborator and colleague of mine. If people are interested in learning more about these kinds of models or research, you could take a look at some really cool work on lamprey spinal cord regeneration from the Marine Biological Lab in the United States. And there's many other colleagues who are doing really spectacular work. Okay, so now we're back to Dr. Feeling's sort of narrative on what happens after spinal cord injury in mammals such as humans. So most of what we know here is from rodent models of spinal cord injury. And these are the molecular and cellular steps that happen immediately after an injury. So this is the little mechanical injury, is the little lightning bolt here. And basically you have disruption of the blood-spinal barrier, you have axon injury, you have a compromised vascular supply. There's a lot of pro-inflammatory cytokine release, and I'll talk about that in a minute. There's demyelination, there's swelling, there's necrosis, so you have a lot of cells dying from the injury itself. Now you get inflammation starting with the pro-inflammatory cytokine release, and you get other cells coming in, which obviously relates to the edema, and you've got pro-apoptotic signaling. And this is all happening in minutes to days. That evolves into vessel thrombosis, axonal dieback, cystic cavitation. There's more and more inflammatory cells that infiltrate, and I'm going to talk about this in more detail in a moment. There's release of free oxygen radicals. There's well, I'll talk about that in a second. Microglial activation and infiltration, and a whole bunch of sort of fast forward toxic events. And then you start to get the evolution of a glial scar, cystic cavitation in humans. So there can actually be a space where there used to be tissue, and you get really restricted cell migration, restricted axonal regrowth, limited remyelination, etc. So this is how the lesion evolves into the chronic phase. Okay, so what I have focused on in my lab is primarily the inflammatory events. And from preclinical studies, we know that immune cells are really pivotal in the local intraspinal events. And for those of you who are, this is not your niche field, there's many different types of immune cells. And what I mean by immune cells are white blood cells that can migrate in from the periphery. And, you know, I just told you that there's also a lot of leakage of the blood-spinal cord barrier, and it's sort of messy, so that cells come in here and they all do different aspects of responding to the injury, and they're not all negative. So we need some elements of wound healing in order to help the tissue restructure, and that's been shown in animal models. There was a clinical trial where people attempted to inject autologous macrophages, which are phagocytic cells, which were injected with the intention of trying to clean up the debris at the injury site. Unfortunately, that failed to reach its primary endpoint, but you know, conceptually, that's the idea, because we do need some wound healing and some controlled inflammation. So many of you have heard in the current era of COVID about the cytokine storm. So what is that? So the cytokine theory of disease, this is a cartoon from another great neurosurgeon, Kevin Tracy, who is our CEO, who was a neurosurgeon by training, the CEO of our research institute at Northwell. And what this really describes is that at low levels, as I said, of injury or wound, you need some leukocyte recruitment, antibacterial activity, et cetera. But as cytokine levels increase and they're uncontrolled, you can have a lot of deleterious manifestations. And that's a similar thing that happens, we think, in traumatic spinal cord injury. There's so much trauma that there's a lot of tissue damage around the area. So it's very hard to study intraspinal events in the clinical setting, but again, another terrific neurosurgeon, Brian Kwan, and his colleagues at University of British Columbia and ACUTE 10 years ago published a really groundbreaking study which showed that cerebral spinal fluid inflammatory cytokines and can be biomarkers of injury severity in the acute setting. And so what's shown here is just on the top panels are some canonical cytokines and chemokines. On the bottom are some very well-known axonal damage markers. And on the y-axis are the levels of these mediators, and on the x-axis are the ASIA scale grades. So you can recall that I just told you that the ASIA A would be the most severely impaired and C would be the least. And so what he has shown here is that some cytokines are directly proportional in the CSF to the neurological exam, the lesion severity, the injury severity, and the same with this panel of axonal markers. And so this really was groundbreaking. What he also showed is that it was just as good, these levels of biomarkers in the blood were just, in the CSF rather, were just as good at predicting recovery at 6 months post-injury as the INSCI exam. Okay, so what we also know is that systemic immune system changes are long-lasting, and that spinal cord injury impacts multiple organ systems. So this is from a recent review from my colleague Phil Popovich at Ohio State, who's a real pioneer in this area of understanding why an injured spinal cord leads to multi-organ failure or dysfunction. And in terms of from the immunological perspective. So the liver has a strong influence on inflammation. Dana McTighe at Ohio State has shown that immune cells, you can have splenic atrophy after SCI. It's particularly true in a level dependent way, and I'll show you that in a moment, why that might be. You have lung impairment, and which can help feed forward in terms of the infection susceptibility. There is gut dysbiosis, so surprisingly to me at least, so there are big changes in the bowel and bladder function after SCI, but the basic science of the microbiome in spinal cord injury is a very new field, and how lesion level or severity might impact that is something that's really interesting, and how that feeds back on the immune system. There are cardiovascular changes, which I'm going to talk about in a minute. There's also decreased, with cardiovascular changes, you can have decreased perfusion to tissues, which can also feed forward on immunosuppression. And I mentioned there's ongoing immune cell trafficking in the spinal cord, and even years after injury in cadaver studies, it was shown that there are inflammatory cells in the spinal cord. Okay, so all of these, there are many different manifestations to spinal cord injury that go beyond sort of the loss of motor function, which is typically what people think of. So really the whole body can be affected. And I just listed some of the most common medical consequences of SCI. So there's impaired pulmonary function, there can be impaired cardiovascular function, there's often accelerated atherogenesis and metabolic syndrome, along with increased fat mass. There's very marked decreased muscle mass. If you're not loading your bones, you get osteoporosis, and often there's an interaction between bone and muscle. So that's a very complex and interesting aspect of this. People with SCI can sometimes have something called heterotopic ossification, where bone forms around joints where it shouldn't be, and that can be very painful and also lead to lots of functional deficits. There can be bowel, bladder, and sexual dysfunction. Many people with SCI live with chronic pain and different types of pain. neuropathic pain being the most severe, which is often described as sort of a burning, tingling pain. People can have interrupted or impaired temperature regulation. So people with tetraplegia have a lower core temperature, which has implications for infection surveillance, et cetera. People can experience spasticity. And then my own research, which is on trying to understand chronic inflammation, how that might feed back on infection susceptibility. And then there's also impaired wound healing, which is potentially extremely serious as well in this population. I just wanted to also give a shout out here to my colleagues at the James J. Peters VA Medical Center, who were really pioneers in describing how SCI affects the whole body. How am I doing on time? Okay, we're okay. Okay, so this is another aspect of how the whole body can be disrupted. So the sympathetic nervous system is also affected by spinal cord injury, and it can be the downstream events can be level dependent. So I'm not going to go through all of this, but I just wanted to mention it because it's important with respect to immune function, as well as to other aspects of living with SCI. So wherever the injury is can damage the sympathetic outflow to organs, and that can have serious consequences on homeostatic functions. Okay, so this is another sort of version of that where it relates to specifically to the immune organs. And this is a cartoon from my colleague Jan Schwab at Ohio State, who's done a really beautiful job drawing this out. So what he's showing in this cartoon is that at the level of T5, you have sympathetic outflow to many of the organs that are immunological in nature. So the spleen, Peyer's patches, lymph nodes, as well as bone marrow. And so people who have injuries at T5 and above would be expected to have immune consequences. And most people are injured above that level. So most people with SCI are living with immunocompromised conditions. And so I told you that infections are the leading cause of mortality in this population, pneumonia and sepsis, the leading cause of rehospitalization. And what Jan and his colleagues showed very recently, about 5 years ago, is that the number of infections that occurs in people during the first year after injury is actually an independent risk factor for poor neurological recovery. So on the chronic scale, we have systemic inflammation, and that can feed back on intraspinal inflammation because immune cells traffic from one area to the other. And if you have systemic inflammation, you can have breaches in the blood-spinal cord barrier as well as the blood-brain barrier. This can also drive immunosuppression. Inflammation dampens neuroplasticity and the effects of rehab, and it can promote many, independent of SCI, can promote many of the medical consequences that I just spoke about. So our approach to trying to contribute to this field is to better understand what are the specific immune system changes in individuals with SCI that contribute to infection susceptibility and ongoing inflammation. And you know, the immune system is inherently druggable. It's something you can sample directly in humans. It's a very attractive therapeutic target. There's many FDA-approved drugs that target different aspects of the immune system. So if we could get a handle on specifically what is going on in this population, you know, we might be in a position to actually do something about it. Okay, so this is an example of some of the work that we've done where we studied T cells in individuals living with chronic SCI. And what we've shown here is that there were fewer CD3 positive T cells, fewer CD4 positive T cells, but the ones that were present were more activated. And this is shown in individuals with neurologically complete, so Asia A and B, motor complete, Asia A and B injuries, as well as in people with injuries at T5 and above, who are the ones who would be expected to have the most immunological consequences. We also showed that specifically a kind of CD4 T cells called T regulatory cells, which also used to be called suppressor T cells, are elevated in people with spinal cord injury, which their role can often be to dampen the immune response. So we think that has implications for infection susceptibility, and we're exploring that. So we've also been interested to try to understand what kind of specific immune system pathways could be relevant to lifelong increased infection risk and persistent inflammation. And so we went back to a very fundamental pathway, which are called pathogen-associated molecular patterns. So we have about less than 20 in humans. These are often called TLR receptors or nod-like receptors, CLRs and RLRs, and their job is to detect microbes and endogenous, as well as some endogenous ligands. So there are sort of emblematic molecules that are present on different classes of viruses or bacteria, protozoa, fungi, et cetera, that are like little flags to these kind of receptors. So they recognize a structural feature of the pathogen. And then when they're activated, they activate the immune response with the intent of clearing the pathogen, and then they activate other kinds of white blood cells in addition to phagocytes, which are supposed to clear them, to have a real immune response. So we know a lot about the signaling cascades that happen downstream of the receptors. I wrote 10 in humans, so that must be true. NF-kappa B and other transcription factors turn on cytokines, chemokines, and help to initiate adaptive immunity. So this is a pathway that can trigger inflammation, and when it's activated long-term, it can also promote immunosuppression. So we did a study, and some of the analysis is still ongoing, in individuals with chronic SCI to try to understand how inflammation might look at really in a detailed molecular level, and how that might relate to some of the symptoms or challenges of living with SCI. So we had 31 participants in this study who had been injured for at least 1 year prior. We asked them to come for 2 visits, held 6 months apart, because we wanted to understand the variation in the chronic phase. And we had 26 able-bodied individuals who were age and gender matched as a cohort. Most of these folks were, their injuries were AIS grade A and D, which is reflective of the US national population. And on average, they were 15 years post-injury. And this just gives you a little sense of sort of their general status. So we used an NINDS common data element to measure overall quality of life, satisfaction with physical health, and satisfaction with psychological health. And while they weren't gigantic changes, they were statistically significantly lower in individuals with chronic SCI. We also used an NINDS common data element for pain to assay pain in these types and their types of pain in these individuals. And most people reported that they did have pain, which is typical for this population. And they actually reported many simultaneous pain problems at the different visits. And so, this is just reflective of the typical experience of living in this scenario. So what we started to do was to measure immune mediators at the protein level in the blood. What I'm showing you here is a study where we looked at 16 individuals with acute SCI, so within the first week of injury, and 47 individuals with chronic SCI. And we measured a molecule called HMGB1, which is an endogenous toll-like receptor ligand. So this is a molecule that's a very ancient, highly conserved molecule that has multiple functions in the body, but it can be a very potent pro-inflammatory cytokine. And what we found is that people with both acute or chronic spinal cord injury had very high levels of HMGB1, higher in the acute setting, which is expected. And then it was not a biomarker of severity because it was elevated in everybody, and also not potentially a biomarker even of injury level, although this was a pilot study. So this is basically something that's pro-inflammatory in everyone, which could really have a strong impact on other inflammatory mediators. So we sort of moved away from this approach of looking at one protein at a time and stepped into the big data approach with RNA sequencing. And what we did was whole blood sequencing from individuals with SCI. And this is a principal components analysis plot of the gene expression of the white blood cells. And in yellow are the people with spinal cord injury, in gray are the able-bodied folks. And you can see that just by looking at the whole blood transcriptional profile that people with SCI are not 100% overlapping with the uninjured group. And this is a 3D plot, which is shown here in one dimension, so it's hard to, but it's hard to appreciate, but they're really quite distinct. And the people who were furthest away from the uninjured population were the people with higher level injuries, which is what we would expect from, based on the preclinical work done by my colleagues showing that animals with injuries at T5 and above have the most profound immune system dysfunction. So that's consistent with this sympathetic nervous system hypothesis, that that's really what's driving immune system changes after SCI. And we then took the differentially expressed genes, tried to understand, well, what are they exactly? And we borrowed a tool from our immunology colleagues where they took 8 infectious diseases and autoimmune diseases, and they tracked empirically which modules, which genes track together with their expression patterns across those settings. And so they set up this map of modules, which they, each of these little modules correlates to a type of function or a cell type. And they have a key of, which genes are in these modules, which track together. And so we plotted our data onto this map. And what we found is, in general, increased expression of inflammatory modules and monocyte-related modules, decreased expression of natural killer cell modules and B and T cell modules. We also then took the differentially expressed genes in individuals with T5 and above injuries and submitted them to different bioinformatics platforms that identify pathways that are enriched in those genes. And what we saw across these different bioinformatics platforms is that the TLR signaling cascade is really highly enriched in individuals, upregulated in genes, is upregulated among the differentially expressed genes in individuals with high-level injuries. So this is, again, independent confirmation from what we saw with HMGB1 that this may really be a very profoundly affected pathway. Another really interesting thing that we saw, so this is just a map from the KEG bioinformatics platform where we're showing that the genes that are in red are upregulated in this pathway in our cohort, and you can see that it's at multiple levels of the signaling cascade. So there's really, really, really a profound effect. What we also saw is profound downregulation of natural killer cell genes. And just to remind you, these are genes, these are cells that they are professional. Their professional job is to kill virally infected cells. They also have a role in bacterial infections. And this was very interesting to us because if you think about pneumonia and sepsis being the most significant causes of death for this population, if you have a profound downregulation of natural killer cell genes, that could really mechanistically explain that. And there were some previous findings from about 25 years ago from my colleagues, Mark Nash, Denise Campagnolo, and others that showed that there were fewer natural killer cells in people with higher level injuries. So in the biomarker space, we're trying to understand also how the immune system changes that happen acutely relate to the chronic state that I just showed you. So most of the time people study either what's happening acutely or what's happening chronically, but we really don't understand how what's happening acutely sets someone up or doesn't for the chronic phase. So we are doing a study with many colleagues around the US and in Canada, where we're recruiting people within the first 3 days of injury, and then we see them again at 3, 6, and 12 months after injury to assay their blood for the types of outcomes that I just explained to you. So the whole blood transcriptome, the proteome, and what's going on at the level of white blood cell populations. And then we also perform the INSCI exam, the spinal cord independence measure, which I mentioned very briefly, which assays sort of how a person is living and functioning with spinal cord injury. And then some of the sites are doing something called the Neuro Recovery Scale exam, which is a physical therapist-based exam where they actually test how is a person able to move, for example, without an assistive device, what muscle groups can they use. And the purpose of this study is to try to augment what Brian Kwan, who's working with us on this study, and his colleagues previously did in terms of understanding if this could be a predictive model of functional recovery, if factors in the blood could relate to long-term recovery. We'd also like to know what's the therapeutic window? Can we actually find things that are different throughout more than a few days, but a couple of months after injury, when it would be a lot easier to conduct a clinical trial to try to intervene. And then we're also looking to see for other studies that are already doing interventions, if we can use this as a comparison to what happens in the blood. So there are strategies out there that reduce inflammation and improve immunity. So ideally, we'd like to have something that has multimodal benefits that would reduce inflammation, boost immunity, lower the risks of cardiovascular disease, et cetera, and do all of these terrific things. So I don't know if any of you can think of something that can do that, but we actually all know that already, which is physical activity. So many professional societies have adopted the slogan, exercise is medicine, and we think that's also true for people with physical disabilities and challenges. There are physical activity guidelines for people with spinal cord injury. It's unfortunately very difficult for people with SCI to access adaptive sports equipment, et cetera, but we are conducting some studies with colleagues, both at the VA using exoskeletal assisted walking, led by Dr. Ann Spungen, and then with other colleagues there, trying different ways of delivering physical activity and to this population, or opportunities for physical activity, and see if we can change immunological health. So I have many colleagues to thank who work with me on an ongoing basis, and I'm happy to take some questions.
All right, I'm going to open the chat up right now so that people can send in some questions.
Okay, should I stop sharing, or what should I do?
Yeah, I would stop sharing.
Okay. Okay, so I should look at the chat and, yep. Okay. I'm going to start at the bottom because I see, what advice would you give to medical students who want to learn deeper about SCI trauma, orthopedics in general? So Dr. Patel gave some really salient advice, I think, which is, start locally. I would, first of all, find out if you have an SCI certified physician at your institution. Many places do not, but you could start by finding out if you have a department of PM&R, or sometimes they could be in the Department of Orthopedics or Neurology, or even some trauma centers have a physiatrist embedded in the trauma center, and reach out to them to start with. It's a really small community. It's a phenomenal group of people. I have never seen such hopeful and kind people who are just really trying to do their best for the patient population as anybody who's in spinal cord injury care. So I highly encourage you to explore it. And it's a very exciting time in the field because there's a lot of new therapies that are being tested. I think that things are going to change in terms of the therapeutic offerings for people with SCI, both in the acute and in the chronic phase. Okay, some other questions. Do you think the cost of a private healthcare system to patients with SCI is fair when the cost of lost opportunity is so high in itself? So that's a really profound question. There's nothing fair about this in any way, in any aspect of this disease or this trauma. So, how are we going to pay, or how do we make payment of healthcare better and faster? It's very cultural in terms of the countries. Every country has a different approach to this. There are national healthcare systems where people with SCI can access all kinds of things that are more on the payer here in the US. There's a lot that can be improved. Okay, what else can I? Is there, let's see, can intense diet, losing too much weight abruptly lead to spinal cord injury? Why? I don't think I understand that question. What else can I look at here? Okay, so this is a colleague who, a comment from a person who has a friend with spinal cord injury who's in and out of the hospital a lot with urinary tract infections, and other types of infections. And that's just a very common reality for people. And it doesn't, as the person comments, they thought it was due to poor nursing care. And after this talk, they could see how it's really might not be. And I think that that's true. There are some inherent just anatomical changes that make people very susceptible to infections. And that's what we're trying to understand. So there's a question, how does physical activity increase NK cells? That's a really great question. So exercise physiologists have shown in able-bodied people that natural killer cells get mobilized from the bone marrow to the blood after aerobic activity. And even walking is something that can do that. So that's one of the health promoting effects of walking in any population. And so we're very excited to think about how are ways to boost the circulation of NK cells in people with SCI or any population with aerobic activity. What is the future of stem cells to regenerate lost neurons? That's a very complex topic. There's lots of different types of stem cells that are being tested in this field. I think that we all agree that a combination of therapies is going to be needed for an optimal outcome. And so it's early days and we really don't know what's the best cell type, when is the best time to implant it, what's the right environment for it to be implanted in, and how does that get integrated into a circuit-like system? How much regeneration do you need? How much replacement do you need? And so these are all really important questions, and there's lots of smart people trying to solve that. Let's see. Anything else that I'm missing?
Right
What
around.
okay. Go ahead.
If you want to say any last thing, answer any last questions.
Okay, can we use spinal tumors and alter them to regrow cells? That's an interesting topic. You know, everybody's worried about ectopic expression of cells in the spinal cord. So people are very skittish about using cell types that have uncontrolled regenerative potential. But conceptually, we'd like to know the genes that get turned on and allow neurons to regrow.
Well, thank you for joining us, Dr. Bloom. I just want to make one quick announcement. Buy the Book is canceled tonight, but we hopefully will be back next week. Thank you for coming. Thank you everyone for listening.
Thanks everyone. I don't have a Twitter handle, but you can email me at obloom@northwell.edu and maybe I'll get a Twitter one. Thanks and take care. Thanks for inviting me.
Bye everybody.